Welcome everyone to the video. Today we have with us Dave Lee from Australia, and he has prepared for us a great lecture on DHEA, Pregnenolone and vitamin D as I have understood it. Okay, Dave, go
Yeah,
ahead.
mainly just DHEA and Pregnenolone today, and we'll do vitamin D next time, just because it's 40 slides already. So
Oh, great.
we'll
Something
uh,
to
we'll
look
keep it short.
out for. Okay, thanks. Go ahead.
Welcome to this channel. I am Dr. Steven de Vos, the lifting dermatologist, and this is my bro science hunting partner Danny Bossa. If you want to learn more about the most cutting-edge science-based information in the world of hormone optimization, please like and subscribe.
Click the bell button to get notified.
I also invite you to join my other YouTube channel, The Lifting Dermatologist. The link you can find in the description of this video.
Okay, thank you. So yeah, today we're going to be going through DHEA and Pregnenolone and their role, particularly in the setting of male hormone optimization. So we're mainly going to be looking under the premise that the individual is already on testosterone replacement therapy. A lot of these concepts will apply to a man who is not on testosterone, but I'll get into the nuances of that a little bit later. So just a bit of background knowledge. This lecture was originally presented and created for educating parents of children with mood disorders in countries where mood disorders weren't treated with your typical treatments that we see in Australia, in the US, and most areas in Europe. So I have adapted most of the content for TRT, and some of this content may be a little bit high level, some of it may be a little bit low level and layman's terms. So hopefully there's something in here for everyone, and it should answer some questions for people who are unsure about the topic. So let's just dive in. So just some housekeeping to get going. I am not a doctor. I am a health coach, but I am not your health coach. So the context of this presentation is purely for educational and informational purposes only. Please don't take any of this as medical advice or health advice, and please work with your doctor on using these hormones. So just the goal of today. The goal of today in this lecture is to educate on the function and the importance of these hormones in the brain and the body, but specifically focusing on the brain. The goal of this is not to have everyone go out, buy a Pregnenolone and DHEA supplement and blindly just start taking them. That is definitely not the intention here. However, the goal is to, treat them with respect, test your levels, review your symptoms, and have an informed discussion with a doctor who is experienced in managing these hormones and the entire endocrine system as a whole. However, from the group that, Stephen has created, I have seen that a lot of participants in the international community may not have access to a doctor who is versed in, a full spectrum of hormone optimization. So, if you live in the US, you've got an amazing range of doctors who you can work with that are featured in the group. I won't get into listing names. But, if you are in the international community, I'm in Australia. We've got plenty of guys in Europe who don't have access to a doctor who treats, the entire hormonal system. So I have included a few recommendations at the end to get you started. But again, please don't take that as medical advice. So just to start with, this is a very basic diagram of the cholesterol hormone cascade. This actually doesn't include all the metabolites, but it does include the main ones. And I am going to keep coming back to this throughout the lecture just for the relevant slides. So just to kind of give you a quick run through, in the top left, we've got cholesterol. And then below that, we've got the cholesterol side chain cleavage enzyme, also known as CYP11A1. From them, we've got Pregnenolone. And excuse me, I'm not going to use the colors here because I'm colorblind. So I'm just going to be navigating across for people. So if we go to the right from Pregnenolone, we have progesterone, moving into the corticoids, and then going down from Pregnenolone after 7A hydroxypregnenolone. We move into the DHEA sex hormones or the androgens, and then moving across into the estrogens. So I will come back to this later in more depth, but as you can see already, Pregnenolone, the reason why it's called the mother or the grandmother or the grandfather hormone is because it sits right at the top, and it is a direct and indirect precursor for the entire hormonal cascade in this regard. So as I said, just to start with pregnenolone, we're looking at the mother hormone. So it is the beginning of the hormone cascade, and all hormones previously pictured come from pregnenolone. It is limited by CYP11A1, also known as the cholesterol side chain cleaving enzyme, meaning that the amount of pregnenolone that you can produce from cholesterol is rate limited by the activity of this enzyme. This enzyme gets a lot of controversy and attention from those who talk about the use of HCG, which we're going to get into too. So it's important to note that pregnenolone is metabolized into what's called pregnenolone sulfate. And while these two hormones do have a lot of similarities, they also have some differences. So I'm going to run through them pretty quick because DHEA also has the sulfated version. So looking on the left, pregnenolone, we've got a negative allosteric modulator of the CB1 receptor. And I'm going to get into what an allosteric modulator is in a sec. It's also a pregnane, I always pronounce that wrong, pregnane X receptor agonist, which is responsible for a lot of the anti-inflammatory properties. And it's a weak positive allosteric modulator of the NDMA receptor. It's also a sigma receptor agonist. And a lot of these properties, it also shares with DHEA. Not all of them, but a lot of them. It is primarily produced in the adrenal glands as well as the gonads and brain. However, it is produced in the mitochondria throughout the body. Pregnenolone has a very short half-life of 40 minutes. That means that once you take a pregnenolone supplement, what you don't convert into pregnenolone sulfate, you will excrete. So this is going to be a reoccurring theme of what we're talking about here, is that as you can see in the bottom right, the half-life of pregnenolone sulfate, 7 to 22 hours, which is significantly longer. So the way that this works in the body is that pregnenolone can be converted into pregnenolone sulfate, and then pregnenolone sulfate can be converted as needed back into pregnenolone. So this kind of works as almost a reservoir for pregnenolone that the body can draw from when needed. And we'll see that DHEA has a very similar function as well. Now, allosteric modulation. This was a much easier concept to describe to a different audience because the proponents of aromatase inhibitors have completely ruined the term sweet spot. So please disregard any negative connotation you have of a sweet spot in regards to AI use, because a sweet spot is very important for many medicines and hormones, but the sweet spot is a lot bigger than, you know, the 22 to 25 range that people wanted estrogen in for whatever reason. So allosteric modulation tends to have what's called a U-shaped response, which is when if we have too little, as you can see on the left, we have a negative response. If we have too much, we have a negative response. A really good example of this is thyroid. If you have too little thyroid, you're hypothyroid. You have too much thyroid, you're hyperthyroid. Both are very different in terms of the fact that they're not optimal, but neither one is better than the other. I mean, you could debate that, but they're both negative in a different regard. So we do want that sweet spot, which is right in the middle. And that sweet spot is quite broad. Similarly, an example I use is caffeine. If you're someone who regularly drinks, 200 milligrams of caffeine a day, that sweet spot for you is going to be probably between 100 and 300 milligrams, whereas none, you're not going to feel great. But if I give you 600 or 700 milligrams, you're not going to feel 3 to 4 times better than 200 milligrams. So keep that in mind. So the role of pregnenolone as an allosteric modulator, and this is just something that I want to define in terms of how it works. So going back, we can see that pregnenolone is a negative allosteric modulator of these receptors. And we're particularly going to focus on pregnenolone sulfate being a negative allosteric modulator of GABA-A receptor. Now, what this function does is it essentially tunes the receptor to be more or less sensitive and to have more or less activity. So the way that I would be very simply describing this function as a negative allosteric modulator, it's essentially turning down the receptor sensitivity of GABA. And what that is doing, it is increasing neurotransmission across the brain, as GABA is our main inhibitory neurotransmitter. So when you consume something like alcohol, a benzo like Valium or Xanax, you're increasing your GABA. So you're increasing the brain's inhibition of your other neurotransmitters. So this is reducing the sensitivity of that receptor, allowing your other neurotransmitters to go further. And the reason why we want the sweet spot for this is if we have too little, we're going to have a negative response. So if this is too low in the body and it's out of balance, it means that GABA is going to be, so if we're talking about a negative modulator here and it's too low, that means that GABA is going to be running too high. Conversely, if we have too much, it's going to be running too low. So we do want that sweet spot here, not too high, not too low. Now, pregnenolone is metabolized differently depending on the route of administration. We're going to get to that later. But for example, instant release oral pregnenolone is primarily rapidly converted into progesterone via what's called a first pass metabolism in the liver. Therefore, the optimal route of administration, which most doctors are aware of by now, is a sustained release, either micronized tablet, sublingual, or transdermal, which I'm going to get into more detail. The sustained release micronized tablets or capsules, depending on how you get them, as well as transdermal, do provide a slow release into the system. Not only do they provide a slow release, but they avoid this first pass in the liver. This allows the body to convert pregnenolone into pregnenolone sulfate more effectively, because you can only convert so much pregnenolone into pregnenolone sulfate, meaning that the success you're going to have with these supplements is going to largely have to do with how well you can convert them into their sulfated form, which I'm going to get back to. Sublingual is also a great form of pregnenolone, and it has been more studied, same with DHEA. And the reason for it being superior is, despite that it does have a rapid uptake into the body, due to that mechanism, it does have more access to what's called the sulfotransferase enzyme. Similarly to when we provide testosterone in a transdermal cream to the scrotum, we get more access to the 5-alpha reductase enzyme. So we're choosing our route of administration so that we have better access to the enzymes that we want to be using. Just a quick note here. So oral instant release hormones do not mimic natural physiology. The body is not equipped or designed to metabolize these doses via route of administration. Similarly, if you inject, a full day or even a full week's worth of testosterone in a water suspension with no ester, you're not going to have a good result because the body simply cannot use it. So what we want to do when we're using these hormones, similarly to why we use either a frequent lower dose of testosterone or we use a slow release ester, is so that we can have a slow release into the system so that the body can convert it into the metabolites that it naturally would if it mimicked our own production. The issue that we have with these hormones, or any hormones across the board when we're doing hormone replacement, is that we're not mimicking natural physiology, and the body doesn't metabolize it into the correct ratios of the downstream hormone metabolites. And we'll get into that a bit further. So just a bit more on pregnenolone. It's actually an excitatory neurosteroid, which is stimulatory. Pregnenolone is often touted for its benefits in terms of relaxation, calmness, supporting sleep. It actually has a lot less to do with pregnenolone itself and a lot more to do with the metabolite called allopregnenolone. Allopregnenolone is the 5-alpha reductase enzyme conversion from progesterone. And we'll touch on more of that soon. So in terms of pregnenolone itself, it's stimulatory, it's excitatory. It increases brain activity. It's also neuroprotective, so it enhances myelination. It modulates cholinergic and dopamine receptors. And in vitro, pregnenolone also protects neurons against toxicity, so it has an antioxidant effect in the brain. In animal studies, pregnenolone also enhances neuron survival. And in vitro as well, which is outside of the body, pregnenolone does increase the growth of new neurons. Low levels of pregnenolone are correlated with dementia, and they're also correlated with poor memory issues, as well as a range of mood disorders. The issue with pregnenolone in terms of study is that although it's been around and it's been used in medicine, since the earlier 1900s, there just aren't a lot of studies on it. So in this lecture, we are going to focus more on DHEA, purely because we have more information. So I don't want this to be selling pregnenolone short. It's just that the information that we have on it is quite limited because the studies just haven't been done. So jumping into DHEA. DHEA is often classified as an adrenal hormone, although it is classified also as an androgen, depending on who you talk to. It actually, at the moment, we haven't located specific DHEA receptors. Now, that doesn't mean that they're not there. We just haven't found them yet, and that hasn't been studied. So we do know that DHEA binds to other receptor sites, including androgen and estrogen receptors. It has a really, really strong mechanism in the CNS, which is the central nervous system, as well as the brain. It acts as what's called a neurosteroid and also a neurotrophin, in the sense that it increases brain activity and also protects the brain. And as with pregnenolone, directly metabolized into DHEA sulfate. So just jumping back to this chart now, so now we're in the androgen section, which is on the bottom left. I'm not even going to try and pronounce the full version of DHEA, but it's just below that 1720 lyase enzyme. So as you can see in this chart, which is a bit limited, but it does cover the most important ones, you've got to the right, we've got androstenedione, and then to the bottom, we've got androstenediol, which is metabolized respectively into estrogen through aromatase, and also into testosterone. And we're going to get into the implications of that when you're on HRT, once we go through the benefits of and the functions of DHEA. So looking here, we've got a lot of similarities with pregnenolone. Again, we've got a negative allosteric modulator of GABA-A. Now, this is why DHEA and pregnenolone, and we're going to get into this at the end as well, need to be given in balance, because if we're jacking both these hormones through the roof, we're going to be turning GABA-A right down, and that can result in a lot of anxiety, and that can result in overstimulation of the brain. Similarly, thyroid is great for increasing metabolism, but if we go hyperthyroid, we become catabolic and our metabolism goes too high. So more is good in terms of optimizing levels, but more is not always better. There is a very broad but very important sweet spot, which will vary for the individual. Now, if we have a look at the half-life of DHEA, we've got a similar story with pregnenolone. So the half-life of DHEA is 25 minutes. That means that when you take an oral, non-micronized, non-sustained release version of DHEA, it's not getting into the system very effectively, because you're not going to be able to convert a whole day or 2 days, depending on how much DHEA you're taking, into sufficient DHEA sulfate. So the most important thing that we're going to be talking about here is not only the quality of the supplement, but the delivery mechanism. Now, there are an extensive list of DHEA benefits because it has been extremely well studied. Stephen has a video with Dr. Keith where he gets into them as well. So if you're looking for some additional information, please check out that video. But I'm just going to run through quite a lot of them, and I'm going to run through them in a surface level kind of fashion, because the benefits of DHEA extend throughout the entire body. So we can see specifically a benefit relating to social anxiety and improving resilience to social stress. There's been quite a lot of studies done on DHEA and improving the resiliency of to stress, particularly social stress. And this comes down to the ratio between cortisol and DHEA. What we do want is we want these hormones to be in balance. And often what happens, particularly with a lot of individuals in a modern society, cortisol is very high. So in bringing DHEA up to an optimal level, we can offset and mitigate and almost antagonize some of these negative effects of cortisol, which seems to be the underlying mechanism in a lot of these studies. So DHEA also has an antioxidant mechanism, which underlies resolving a lot of issues of brain fog and migraine for people. So often when I'm working with people who have migraines, brain fog, issues relating to cognition, but as soon as I hear migraine, assuming that there's not some kind of injury or structural issue with the neck or spine, I'm looking at DHEA levels straight away. DHEA decreases while DHEAs, which is DHEA sulfate, increases what's called brain-derived neurotrophic factor. If you want to do some research into that, I highly recommend looking into it. That's essentially the brain's ability to adapt, grow, and form new neurons, and it's very, very closely associated with mood. With a lot of these points, you'll see that DHEA and DHEAs will have different effects. And some of the effects are agonistic and antagonistic. And this is coming back to the importance of the ratio between DHEA and DHEAs and the ability to create the sulfated form. Moving down, so DHEA enhances mitochondrial oxidative capacity, improving central nervous system metabolism, while DHEAs promotes long-term resilience of neurons against insults. DHEA protects and repairs damage from the insult. So this is how DHEA and DHEAs are working in tandem to have a really beneficial effect in protecting and supporting the brain. DHEA also protects against neurotoxic effects of excess glutamate, which is an excitatory transmitter, as well as corticoids, which is the cortisol factor that I was talking about before. Lower levels of DHEAs are also correlated with worsening of neurodegenerative disease symptoms. So this isn't saying that low levels of DHEA will cause a neurodegenerative disease. It's saying that in the case that those diseases are already present, lower levels tend to be associated with worsening of symptoms, and improving the DHEA level through supplementation tends to improve these symptoms. And this is not limited to any neurodegenerative disease, but it's most commonly seen in terms of where it's been studied in Alzheimer's. Okay, getting through these quick. So DHEA improves decision-making in multiple trials. The mechanism for this isn't too well identified, but it's believed to be to do with offsetting the negative effects of cortisol. DHEA and DHEAs increase signaling in the brain. This is through the GABA-A allosteric modulator negative effect. DHEA improves symptoms of memory loss in rat models of Alzheimer's, which is what was discussed a moment ago. DHEA increases acetylcholine release in the hippocampus. Acetylcholine is extremely important in the brain for processing and storing information. 30 to 90 milligrams of DHEA has been shown to increase DHEA levels to mid to high normal levels, and improvement in the ratio between DHEA and cortisol, which significantly improved the symptom of depression in this study. 60 to 90 milligrams of DHEA significantly outperformed placebo in a 6-week trial of 22 patients with depression. And this is one of my favorite, if not my favorite trial of DHEA for mental health. The interesting part of this trial is that it was a 12-week trial. So for the first 3 weeks, they gave 90 milligrams of DHEA, which is a high dose. For the following 3 weeks, they gave 450 milligrams of DHEA. This is the highest dose that I've found in a study. For 3 weeks, and then 6 weeks of placebo. The psychological symptoms of depression greatly improved, but the baseline level of DHEA did not predict the response. Therefore, those with low DHEA levels versus those with high DHEA levels both received similar benefit. So what was argued out of this study is that it wasn't simply correcting a deficiency. It had a mechanism beyond that, which is saying that, and it's implying that mood disorders can benefit from pushing DHEA levels higher than what we see in the natural range, which is extremely interesting for psychiatrists, psychologists, and mental health professionals who want to work with depression outside of traditional antidepressant drugs. DHEA has some really interesting mechanisms on dopamine as well. So it increases what's called tyrosine hydroxylase, which is a rate-limiting enzyme in the production of dopamine. So what this is essentially doing is allowing your brain to create more dopamine from the precursor tyrosine, which is an amino acid. DHEA is also a D2 receptor antagonist. So it antagonizes the D2 receptor, but it also antagonizes the autoreceptors. So as a result, theoretically, it could also increase dopamine release and transmission. Now, DHEA does inhibit the inhibitory effect of dopamine on prolactin, and that's a double negative. So I'll just explain that quickly. So dopamine is known to inhibit the release of prolactin. And what this study is showing is that DHEA actually stops that effect from working, which is arguably due to the D2 receptor antagonism above. However, the metabolite 7A hydroxy DHEA does inhibit prolactin on its own, so this effect is essentially neutralized. DHEA sulfate increases D1 receptor activation, and this is through the sigma receptor. So when you look at these two pieces of information together, you can almost draw the conclusion that it repartitions dopamine signaling away from D2 and towards D1. This tends to be more stimulatory and can really, really benefit some people's neurological profiles. So through this, DHEA is increasing dopamine in the short term through the inhibition of autoreceptors, while DHEA sulfate is increasing dopamine long term with the longer half-life and being able to create more dopamine. It's also increasing nitric oxide, and oddly enough, it's actually been found to increase allopregnenolone levels, despite the fact that it is not a precursor for allopregnenolone. So that is most likely coming down to the cortisol offsetting effects. Last one on this, and I'm just going to run through these quickly, as these are the ones that Dr. Keith particularly mentioned in his video. So DHEA improves the body's ability to burn fat. It improves insulin sensitivity. It decreases visceral body fat, which is extremely important. It increases glutathione, which is your body's main antioxidant. And it also improves bone mineral density. It also significantly improves liver function. And this is particularly in subjects with fatty liver disease, which is often correlated, and I'd also say as a result of insulin resistance. So you can see how those mechanisms are supporting each other. Now, do you have any questions before we move on? All good? Okay. So this is what a lot of people are going to want to be knowing from this discussion, which is, how can I supplement with Pregnenolone and DHEA, and what can I actually do to support my levels? And despite the benefits of Pregnenolone and DHEA, my recommendations are quite modest and mild compared to most. So we'll get to that shortly. So due to the precursor nature of Pregnenolone, it will increase DHEA levels somewhat. The degree to which it will increase your DHEA levels can range from virtually none, and I would say negligible, to it can provide an adequate increase to bring your DHEA levels to optimal. This will completely depend on the individual's activity of the enzymes, which are downstream from Pregnenolone. So how it will affect your DHEA levels for Stephen would be completely different to how it affects mine and how it affects yours who's watching this. So keep that in mind. Pregnenolone levels may be reduced in individuals which have the TSPO mutation. This is a mutation particularly relating to the cholesterol transporter, and this tends to result in lower pregnenolone levels across the board for individuals with this mutation. And it particularly results in lower allopregnenolone levels, which can result in some negative symptoms. So if you do have your genetics tested, this is something that you can look at. And if you do have this TSPO mutation, it means that pregnenolone supplementation isn't vital because there are compensatory mechanisms for this. But if you're already on testosterone replacement, getting a mild reduction in pregnenolone, your natural ability to produce it is already slightly compromised, you would probably benefit from at least looking into it. Increasing pregnenolone can also promote wakefulness and sedation. So some people, when they take pregnenolone, will get a lot of energy, they'll get a lot of vigor, they'll get wakefulness, and it will actually interfere with their sleep. Other people will have a very sedating effect from pregnenolone, and it will virtually act as a sleep aid or a relaxant and knock them out. So it's going to be highly individual, and it's going to depend on your metabolism and your need for certain hormones. For me, if I take pregnenolone, it makes me very tired, lethargic. So if I was to take it, I would be taking it before I go to bed. However, I have worked with people who, if they take it, they can't sleep for at least 12 to 14 hours after taking the supplement. So very, very, very different depending on your individual biochemistry. Studied doses of pregnenolone have gone up to 400 milligrams. This is a very high dose, similar to DHEA. I wouldn't recommend taking or starting with 400 milligrams. But keep in mind that dose has been studied, and although the trials were relatively short term, it has been shown to be safe. DHEA supplements, it looks like I didn't update this version of the slide. Very, very similar to pregnenolone regarding how you will be metabolizing it, in that it will affect everyone differently. The important thing to note with DHEA, which I'm going to jump to in the next slide, is how it gets metabolized a little bit differently when we're on exogenous testosterone, and how it can drastically increase your levels in the bloodstream, so your levels of DHEAs, even with low doses. So when we're supplementing with neurosteroids, protocols largely vary across who's recommending what in the space. I've seen some people recommend as little as 5 milligrams to start. I've seen other people recommend 50 to 100 milligrams. It is very different, and whether you start high and work down, whether you start low and work up, that's up to your doctor and your doctor's expertise in not only dealing with other patients who've had similar deficiencies, but also understanding your biochemical individuality and how you will respond best. So work with your doctor on this. Pregnenolone and DHEA are very powerful hormones. They have a lot of effect in the body, and they affect a lot of things downstream from them. I know that they're over the counter in the US, but in Australia, pregnenolone and DHEA are actually scheduled at the same level as testosterone. So they are considered, they're scheduled, they're protected, and they're very difficult to get a prescription for. What's the legal status like for you, Stephen?
It has to be prescribed by a doctor here.
Yeah.
But it's easy to get. I can prescribe it. Some doctors even prescribe it for anti-aging reasons, especially dermatologists. But yeah, that's a bit off-label. But it's very easy to get. But you need a prescription. But every general practitioner will prescribe it for you if you ask it.
Yeah, interesting. Yeah, so it's very varied and very different. But yeah, keep in mind that if you are in the US and you do see it on the shelf of Vitamin Shop or Walmart or wherever you're shopping, it's a lot more powerful than the other vitamins and mineral supplements that it's sold with. So keep that in mind. Just because it's over the counter doesn't mean that it's mild. And quality is one of, if not the most important factor when considering a DHEA, pregnenolone, or any hormonal supplement. The difference in quality is going to be the difference between you getting it into your bloodstream. You also don't know if it says 50 milligrams on the label, if there's 50 milligrams in there, and then how it's manufactured is going to depend on how you can metabolize it. So if you can get access to a prescription version, that would always be best. Otherwise, the version that I recommend if you are to get an over-the-counter version is called Nutricology, is the brand. I found that they have offered similar levels and effects for people who have gone on and off prescription versions of the hormones. So I'm just going to move my window so I can see what I'm talking about. So your ability to tolerate DHEA and pregnenolone will greatly depend on your ability to create the sulfated forms. So a lot of individuals will have polymorphisms in the sulfation pathway. And this means that they won't be able to generate as much of the enzyme required to convert either pregnenolone or DHEA into their sulfated forms. The way around this is to increase your ability to produce this enzyme. So the three ways that I would consider the best are to increase your cholesterol intake, to increase your sun exposure, and that's not vitamin D supplementation, sun exposure, and to also increase your intake of foods containing sulfur. N-acetylcysteine has also shown in quite a few studies to be beneficial for increasing this enzyme, as has whey protein. San Pellegrino mineral water is quite high in sulfites, and the king of this is egg yolks. That's really only important though if you do have a polymorphism in that enzyme. So most people won't have to worry about that, but it is worth noting that if you do have that issue, you can take means to support it. Where am I? So If you do have those polymorphisms as well, I would also be looking into taking lower and more frequent dosing so that you can deal with your body's ability to have a lower amount of that enzyme and still have an optimal ratio between the neurosteroid form and the sulfated neurosteroid form. Now, the most common forms of supplementation are sublingual, topical, which is a cream, oral, and sustained release oral. Now, the limitation of the micronized sustained released oral form is that there aren't really any studies. So what we can do, however, is we can deduce from the mechanism and also from other studies how this is going to be beneficial. So the function of a micronized sustained released oral form is that it will bypass the first pass liver metabolism and it gets slowly absorbed through the lymphatic system. This is very similar to subcutaneous testosterone injections, which provides a slow, steady release. So think of an oral micronized released form as a very similar to a sustained release tablet or pill that would break down slowly due to the coating or the release mechanism of the drug. Now, the highest increase in sulfated forms of these hormones are actually seen via the sublingual form, which was mentioned before. Topical forms do work well, but they are less bioavailable, typically. And this will also depend on how the cream is compounded, what ingredients are used, and the quality of the manufacturing. So it's important to keep in mind, particularly with creams, but with all these hormones, it's about quality and consistency, because one brand might deliver a completely different dose and a different effect in the body to another. Due to the fact that topical forms are typically less bioavailable, for those who are very sensitive to these hormones and only need a very low dose, a topical form might actually be beneficial in embracing that lower bioavailability, but still skipping the first pass metabolism in the liver. There are no set recommendations or doses for these hormones. So any recommendation that you are getting as a starting dose or as a blanket dose is completely subjective. Even with the literature for testosterone, we usually see 250 milligrams every fortnight, which isn't what most people do best on, but at least that's a starting point. DHEA, Pregnenolone, there's nothing really like that in the literature or the guidelines. Keep in mind as well that no form is 100% bioavailable. So if you're putting in 50 milligrams of DHEA, whether it's oral, sublingual, whatever form, your body is not getting 50 milligrams of DHEA. So keep that in mind. Supplementing will add to your own endogenous production. And this is a really important point that I think is overlooked or disregarded or even just not considered by some people who are taking on a DHEA or Pregnenolone protocol. So if I was to give you 50 milligrams of testosterone in an injection, that is going to shut down your luteinizing hormone, and that is your new 100% of the testosterone in your body after a few days where your endogenous production has been metabolized. So it doesn't matter if you have a level of 200 or 600 testosterone starting TRT. That doesn't affect the dose that you're going to need to reach, let's say, a level of 1,000. It's not important. However, with these hormones, you're adding to your own production. So the degree to which you have a deficiency will determine the dose that you need. I do believe and have seen in some studies that if you do take a very high dose that goes beyond the body's natural endogenous production by a greater scale, it will shut down your own production temporarily, which is similar to what we see in thyroid. But if you are taking a low dose, you're simply adding on to your endogenous production. And this is because these hormones are made in the mitochondria. They're made throughout the body. Taking one dose or taking an ongoing dose will not shut down that production because the body needs these hormones, particularly pregnenolone, as a precursor to cortisol to survive. So if I gave someone a pregnenolone supplement and it shut them down and I stopped giving them pregnenolone, their cortisol would go to zero and they'd drop dead. It doesn't work that way. The body is a lot smarter and a lot safer than that. So we don't have to worry about shutting down our own production. Although if we take a high dose, we could temporarily down-regulate the production that we have. So recommendations will vary from 1 to 2 milligrams up to 100 milligrams for both hormones. If you're not working with a doctor, and if you're managing these yourself for someone in the international community, start low. 1 milligram I have seen have a profound subjective effect and also a notable effect on blood levels. Some people only need 1 or 2 milligrams of these hormones. Ray Peat has a really interesting article on DHEA, pregnenolone, and I believe progesterone is the third hormone that he talks about. And he mentions that he sees 3 to 5 milligrams of DHEA restore hormones to a natural level for many of the men and women that he's worked with. However, there are numerous studies that show that 5 milligrams, while it will restore youthful levels, other studies, and there's plenty of these, have shown that any less than 30 milligrams or even up to 50 is completely ineffective in shifting the DHEA level. So there are massive, massive differences in not only your unique bio-individuality, but also the quality of the supplements and the forms used. Most of these studies tend to just be an oral form. So there's a lot of different factors at play there. Now, I'm just going to go into a few of these myths, and then I'm going to go on to some of my own recommendations as well. So one myth is that TRT shuts down pregnenolone production. This is false. Testosterone replacement therapy does shut down CYP11A1, which is the cholesterol side chain cleaving enzyme, in the Leydig cells, which are the cells within the testicles. It does not shut down the production systemically. I can't stress that enough. That tends to get thrown around consistently. It does shut down LH, but the effect of LH on pregnenolone is considered to be very local to the Leydig cells. So if you find any studies on that, if you do some reading, it should be in the abstract. It will be specifically talking about the Leydig cells. Pregnenolone is produced by the mitochondria throughout the whole body. Now, I did mention cortisol earlier, and I realized I didn't elaborate. So of all the hormones that we have in the body, we can survive with very low levels. We won't do well and we won't thrive. But if testosterone goes to 0, estrogen goes to 0, DHEA goes to 0, we will live to see another day. If cortisol goes to 0, you're dead. That is the hormone that the body cannot live without. We need at least a little bit of cortisol in the system to survive. If pregnenolone got shut down by TRT, every bodybuilder who's ever done a cycle without taking HCG or pregnenolone would be dead. It doesn't work like that. So please keep that in mind. However, because of this action where it is reducing the CYP11A1 in the Leydig cells, it will likely reduce pregnenolone slightly. You're taking out, a major factor in the production of pregnenolone and also the synthesis and production of progesterone. So it definitely will create a reduction. The extent to which this is significant or worth replacing or even bothering with is subject to a lot of debate. My opinion and my thoughts on the matter are that because we are replacing testosterone at an optimal level, this is one of the main final metabolites of pregnenolone. So I believe that we do have a lower requirement for pregnenolone levels when we are on exogenous testosterone. That's not to say that it doesn't matter and that if you are pregnenolone deficient, that you shouldn't address it. What I am saying is that someone on TRT with optimal testosterone levels could potentially get away with a little bit lower of a pregnenolone level than someone who is not, because we've already taken care of a major role in the production of testosterone and the function of pregnenolone. That is my opinion, and others will disagree with that, and I could argue the other side of that statement as well. Next one. TRT shuts down DHEA production. This is definitely not true. DHEA has actually shown in studies to increase as a result of administering exogenous testosterone, as well as exogenous DHEA. So what that means is that if you take DHEA, according to some studies, your body will not only increase its levels from the endogenous form, but it will also be increasing its own exogenous production. This means that a little bit of DHEA, depending on the individual, can go a long way. Also with testosterone, I have seen some guys have a drop in DHEA, but I've also seen a lot of guys, I would say the majority, actually have an increase in their DHEA levels. Now, whether that's enough of an increase to take them to an optimal level completely depends on their baseline, completely depends on their adrenal health, their stress, their diet, and their general bio-individuality. Now this just didn't update properly, that's okay. Now it's important as well, this is just a second point, DHEA has had extremely mixed results in increasing both androgens and estrogens in males and females. So one myth is that if you take DHEA while on TRT, you will increase your testosterone. So let's say if you had a total T of 1,000, some arguments are that because testosterone is a metabolite of DHEA, that if you threw in 50 milligrams of DHEA a day, that would bump your levels up to higher than 1,000. Generally not the case, and I see that in blood work. Most doctors have also seen the same that I've spoken to, and this is actually due to a downregulation of the 17B-HSD enzyme, which we see on TRT. And I'm just going to show you what that means now. So if we go down to DHEA, if we look at the rectangle directly below it, which is running horizontally under DHEA, I've got my cursor. So this one here, this enzyme, as a result of shutting down LH, so often we focus on the fact that CYP11A1 is shut down and reduced in the Leydig cells following TRT and the reduction of LH. This enzyme is also significantly reduced in the testicles, meaning that DHEA is preferentially converted via aromatase into estrone and then estradiol. So very, very little. It doesn't shut it down to zero, but it does significantly reduce it. Very little DHEA when you are on TRT will make it down to testosterone. This is why it is very important to take the optimal amount of DHEA if you are supplementing it, and that more is not always better. One side effect that I see and I hear all the time, DHEA gave me acne, DHEA gave me erectile dysfunction, DHEA gave me all these negative symptoms, which have typically been associated with a poor testosterone to estrogen balance. It's because it's just getting shafted right along here to the estrogens. So it's not saying that DHEA is a negative thing to take, because we're all aware of the positive effects of estrogen in the body. What we are saying is that you want to keep it all in balance, because if you weren't on testosterone and you took DHEA, you're going to be getting a conversion to both testosterone and estrogen. So what I actually recommend regarding DHEA is a lower dose for the guys who are on TRT than someone who I'd recommend who is not on TRT. If pregnenolone is low, you should supplement pregnenolone straight away. That's not something that I personally recommend, and this is why. So pregnenolone is made from cholesterol. Cholesterol has some very, very important functions in the body, and a lot of people's diets are deficient in cholesterol. We can make our own cholesterol. However, the function and this backup mechanism that we have in our body to produce cholesterol to keep us alive so that we can keep cortisol functioning in the absence of cholesterol in a diet doesn't allow for optimal levels. It allows for some levels, not optimal. So my first recommendation is, after cleaning up the diet and removing inflammatory foods, is to increase cholesterol to an optimal point. So not going overboard and eating an insane amount of animal fat, eggs, and saturated fat, but getting the optimal amount of cholesterol in. After that, if that fails, then I would be looking at pregnenolone supplementation, absolutely, but it would not be my first stop, depending on the individual's diet. Okay, HCG backfills the DHEA and pregnenolone pathway. This is an interesting point that gets thrown around a lot. Some of it is true, some of it not so much. So I would say that HCG facilitates the backfilling of this pathway, but it does not backfill it on its own. I've seen plenty of blood work, and I'm sure others have seen this too, where people will introduce HCG and their DHEA and pregnenolone levels will, go up by 1 or 2 points. While HCG activates the LH receptor and increases CYP11A1 as well as 17B HSD, which we went through earlier, this does not increase pregnenolone and DHEA function beyond what it was pre-TRT. So if you were, having secondary hypogonadism, and when you started TRT, you had low DHEA, low pregnenolone, there's a good chance that that pathway has an issue, and keeping that pathway online, it will preserve those levels. They probably won't drop, but they probably won't go up. It completely depends on why the levels are low in the first place. And if there's an issue in that pathway, keeping HCG in the mix to allow those enzymes to be functioning does not increase these levels optimally. What it does do, however, as I mentioned before, if I'm just going to go back to here, it will increase the activity of the 17B HSD enzyme, as well as the CYP11A1 enzyme in the testicles. So DHEA will metabolize and convert and flow better to allow for endogenous testosterone production. So it will facilitate this path working properly or optimally, but it will not increase this level systemically in the body. It will increase it in the testicles, which is great for endogenous production. But in terms of the neurological functions of pregnenolone and DHEA, it's going to have a negligible effect. Okay, so I jumped around. Yeah, okay. So another myth is that everyone on TRT needs pregnenolone and DHEA. I don't think this is the case. I think a lot of people will benefit from pregnenolone and DHEA, but I wouldn't say that everyone does and will need them. One of the big determining factors of if and how much pregnenolone and DHEA you need or will need is your age. So if you're a younger guy who starts on TRT, if you have a testicular injury or you have an issue such as myself, and I started, TRT in my mid-20s, my pregnenolone and DHEA levels are fine. And starting TRT did not impact them negatively. Therefore, I do not need pregnenolone and DHEA. And when I take them personally, I get negative side effects because it takes my levels too high. That's me as an individual. If you are having, secondary hypogonadism at the age of 40, 50, or 60, you will benefit from DHEA and pregnenolone most likely just as much, if not more, than you benefit from testosterone for mental function. So it's important to keep in mind that this is individual, and there are a lot of factors relating to if and how much of these neurosteroids you will need. I think that as we age, we will inevitably all need to go on pregnenolone and DHEA at some point, but that isn't right now for everyone, particularly the younger guys. And thyroid also goes into that equation as well. So it's important if you are on TRT, if you're younger, and if you don't need pregnenolone and DHEA now, you may need it in the future. So regular blood work is important. If you've been taking pregnenolone and DHEA for 5 or 6 years and you've been taking the same dose, I would be getting some blood work done because maybe your endogenous production is declining as you age, and you could use a little bump up in your dose to keep you at optimal levels. Whereas testosterone, your level is likely to stay, the dosage that you need is likely to stay a lot more static. So keep that in mind. Everyone will benefit from pregnenolone and DHEA. As I said, too much of these hormones will create a negative response, as with too little. It will be a different kind of negative response, but just like I said, hyperthyroidism isn't any more fun than hypothyroidism. Although the negative response will be different, again, neither will provide the subjective benefit. Now, depending on the individual, low normal levels of DHEA and pregnenolone may be better suited for their biochemistry than youthful or higher levels of DHEA and pregnenolone. Now, this is a catch-22 because it's a bit of a trade-off. However, as I mentioned, that as these are stimulatory neurotransmitters, if you are someone who has GABA issues, if you're prone to anxiety, if you're an overstimulated, anxious, highly strung kind of person, you may find that if you jack these levels up to a youthful level, that it does not suit your neurochemistry. It might make you anxious, it might make you uncomfortable, and you might feel better with low normal levels. This for me is fine. I wouldn't have you at a deficiency. And if you were, completely deficient, I would want to see you in at least the bottom third of the reference range. But some people will do better with low normal levels than high normal levels. And that's really important to keep in mind. Not everyone will function their best with a high level. However, I will add that if you can get away with a high level, you will get more benefits systemically from these hormones. So it's best to have the level optimized to what you can tolerate as an individual. And again, just as I said, everyone can tolerate DHEA and Pregnenolone. Another issue I see, which I touched on earlier, is that if you have issues creating the sulfated form, you will need a much lower dose of Pregnenolone and DHEA, and you will definitely need an extended release form or a sublingual form, and you will benefit from lower, more frequent dosing. As I said, issues with the GABA receptor will create anxiety. And another issue for people who are deficient in 5-alpha reductase, this enzyme is responsible for converting testosterone into DHT. It's also responsible for converting progesterone into allopregnenolone. So if you're taking pregnenolone, it's making you anxious, it's not making you calm, and it's contributing to some overstimulation that's uncomfortable. I would be guessing, and I want to be looking at blood work and genetics for this, that you're not effectively converting it to allopregnenolone, and that is resulting in your negative symptoms. So I would be working with your doctor to address that and potentially taking allopregnenolone directly to compensate for that lack of enzyme activity. Again, something to work with your doctor on. I do know a couple of guys who've experimented with applying pregnenolone as a cream to the scrotum to get more of that 5-alpha reductase activity similar to DHT. I haven't experimented with that myself, can't comment on that, but that's just something that I've seen working for some guys. So these are just kind of my 2 cents here. So for guys who are more confused now than they were before they started the video, I'm sorry. But information is the most important thing here. So for me, when I'm working with guys from a coaching standpoint, I first identify pregnenolone deficiency symptoms, as well as low cortisol, low progesterone, and low DHEA. So we know that pregnenolone blood tests are not accurate. This is because pregnenolone fluctuates throughout the day. Your reading at 10 in the morning is going to be drastically different than 2 in the afternoon. It does not act as a surrogate marker for where your levels are over a 24-hour period. So I identify low pregnenolone as A, symptoms, but also seeing if the client has low cortisol, low progesterone, and low DHEA. Because if we go back to the pathway here, if this is low, if cortisol is low and DHEA is low, and they're all low, and they've got symptoms, I'm guessing there's not enough of this to go around. So that's a really good way to make a diagnosis on that, as the pregnenolone blood test is not very effective. If the individual is not feeling good and they have average DHEA adrenal hormone levels such as pregnenolone, I'm probably not going to mess around with those levels until I find out what the root cause of the problem was. If you feel like rubbish and you've got a DHEA and adrenal levels, in the mid-range, that's probably not why you feel like crap. Now, optimizing them and bringing them up, will that make you feel better? Probably. It's not why you feel garbage. So that's how you go from a 9 out of 10 to a 10 out of 10, not how you go from a 2 out of 10 to a 10. And that's really important. I think a lot of guys, they don't feel good. There's something off either in their protocol or elsewhere. and they immediately start, messing around with Pregnenolone and DHEA that they buy online. That's just adding to the problem, guys. I really wouldn't be recommending that. However, if your Pregnenolone and DHEA levels are in the gutter, if they're really low, that could potentially be your root cause, and I would be treating that as priority. So always go for the lowest hanging fruit, and then bring everything else up once you're feeling good. As I said before, optimizing DHEA and Pregnenolone levels is more a concern for people who are older, because these hormones decline over time, just like everything else. Just as a side note, from starting TRT, looking at pre-TRT, post-TRT blood work, I have never, ever seen a TRT-induced adrenal deficiency. So I've never seen someone go from having great adrenal function to adrenals in the gutter from using TRT with or without HCG. At the same time, if you have adrenal insufficiency or you have low adrenal hormones prior to TRT, adding in TRT probably won't fix it. You might get a little bump in DHEA, but those fatigue symptoms that you are having, which you may have thought were related to low testosterone, it's not going to fix them. So you need to focus on working with a doctor who understands this and can give you the best treatment that you need. However, for those who do not have access to a doctor like this, and for those who require these hormones, when I work with these guys, I recommend a 1 milligram sustained released or sublingual form and titrating up with regular blood work. This is because I'm a coach, I'm not a doctor. I'm not confident saying, here's 25 milligrams of DHEA, this is going to be what's going to make you feel good. What I am confident in saying is, here's 1 milligram, work up slowly, and be in tune with how you feel and how your body feels. I've had plenty of guys, push their DHEA up by a few hundred points, resolve any of their adrenal insufficiencies by taking 1 to 2 milligrams of each of these hormones twice a day. Some guys need a very small amount. I've also seen guys who need, 100 milligrams of Pregnenolone, 50 to even 150 milligrams of DHEA. Hugely different, but it's much easier to start low and work up than start high and work low. If we, do take this slowly, it's not the end of the world. You will gradually be feeling better if this is the root cause of your problem. And it's much easier to do that than to start high and to mess around and jump around with different dosing. So that's what I recommend. If you do get the Nutricology brand of these supplements, by the lowest concentration, I believe DHEA comes in a 10 milligram scored tablet. Cut it up and take 1 little piece, every day, and work up to a dose that reflects good symptom resolution and good blood work. That's all I can recommend. If you're not working with a doctor and you're doing this on your own, you need to get regular blood work. Doctors may be able to get by with not running blood work as much because they have more experience. Don't play Russian roulette with your endocrine system. Get blood work. If you're not seeing a doctor, use that money on blood work. Simple. Pregnenolone can be dosed once or twice a day. This will depend on how you respond to it. Some people can take it morning and night, and it will give them better energy throughout the day, and it will help them sleep. Some people need to take it once a day. Whatever works for you is fine, but if you can get away with it, twice a day is probably going to be better because you'll have more stable levels. DHEA is best taken in the morning because this reflects your circadian rhythm. It can be taken at night by all means, but most people find that they have a better sleep quality and energy throughout the day if they take it in the morning, but totally up to you. That's just my recommendation. As I said, if any individual is not feeling well and their DHEA/Pregnenolone levels are mid-range, I wouldn't place it as a high priority. If they're not feeling well and the levels are low and they're having adrenal insufficiency symptoms, I would be placing it as a high priority. When optimizing and treating adrenal insufficiency, you have to look at the thyroid. You can't just look at these in isolation, because if you jack up your adrenals and your thyroid is hypothyroid and it's low, it's going to make that deficiency more pronounced because the ratio between the two is now off. So if they're both low, you'd probably feel like crap. And if you just jack one of them up and leave the other one low, you're just going to feel like a different kind of crap. You need to have them in balance. That's the most important thing. There's a website called Stop the Thyroid Madness. I'd really recommend checking out some of the blogs on there because they talk about how symptoms of adrenal insufficiency and thyroid insufficiency kind of go hand in hand. And if you correct one and not the other, you're just going to create more problems. So you need to look at both. If you're going to have high optimal thyroid function, you need high optimal adrenal function to support it, and vice versa. Given the importance of the balance between cortisol and DHEA, it's really important as well to measure these levels before either introducing pregnenolone or DHEA in isolation or taking them both together. So if you've got low cortisol and you up your DHEA, that ratio is going to go off and you're going to feel like crap. If you've got high cortisol and low DHEA and you take pregnenolone, you're going to feel like crap. It's not the hormones that are making you feel bad in themselves. It's the fact that they're not in balance in your body. That is the most important thing. None of these hormones have a negative effect. The negative effect comes from them not being in balance. I can't stress that enough. So if you're not working with a doctor, you must get blood work, you must start slow, and you must learn to understand and treat your own body based on blood work and symptoms, not just throwing down 100 milligrams of pregnenolone and just see what happens. So take home points, test, don't guess. Again, if you're not working with a doctor, use that money on blood work. But I would highly, highly, highly recommend working with a doctor who understands this stuff and can do the guesswork for you. That's what they're there for, guys. That's what they're trained in. That's what they do. I am not a doctor. Stephen's a doctor, but most people watching this are not a doctor. So go and see a doctor to manage these for you. Again, too much is not. So too much isn't better than not enough. They're both not ideal. So there is a sweet spot. Again, that term has been tarnished by people who took too much Arimidex and stressed the estrogen sweet spot, but there is a sweet spot. It is broad. It is going to be very individual. But don't keep thinking, oh, I want to keep upping my DHEA and pregnenolone because it's got all these benefits. Same with thyroid. Best example, having an optimal thyroid is great. Having too much thyroid beyond that is catabolic. Same with these hormones. More is not better. Optimal is best. As I said, pregnenolone and DHEA do not cause negative effects. The negative effects are caused by the fact that you either didn't need it in the first place, or you've created an imbalance by treating one hormone and not the other. So keep that in mind. We don't all need these hormones. We don't all need them in the same dose. We all probably will need them as we get older or as our natural production declines. Work with a doctor who knows this. You shouldn't have to do this yourself. If you do this yourself, you are likely to kind of run into some hiccups. So we've got some amazing doctors in this group. If you have access to them and they can legally treat you in the US, you will save more money and time just by going to them than playing guesswork and playing Russian roulette with your own endocrine system. So work with a doctor who you trust and who knows this stuff. And if you are going to manage yourself, if you have no other choice, start low, go slow, work up. 1 milligram of these hormones does have an effect. There are plenty of articles on this, plenty of studies that show this. So you don't need to start with 50 milligrams. You don't need to start with 25. Start with 1 or 2 and work up gradually over time. You'll give your body a chance to adjust. You'll be able to find what suits you based on your blood work, and you'll avoid any negative side effects. These hormones do take a while to clear out of the system and their metabolites. So if you are throwing around different dosing and it doesn't work for you, you're going to feel off for a little while. So start low, work up. That's the best thing you can do. Just a reminder one more time, I'm not a doctor. This is not medical advice. I'm a health coach, but I'm not your health coach. So please just take this information as educational. I really, really hope that this has helped you in your understanding of DHEA and Pregnenolone. And what I'll be doing after this video is I'll be sending Stephen a list of all the studies that were cited in the order that they appeared. And that way he can just copy and paste them in the description if you'd like to read these studies or make your own conclusion, because most of this was my opinion, but I hope it helped.
Yeah, Dave, that was an amazing lecture. Thank you so much for that.
Not a problem.
I think that will help out a lot of men with a lot of questions that we get every day in the group, in the YouTube comments and so on. And personally, I learned a ton as well. So thank you so much again.
Awesome. Not a problem. Do you have any questions or anything you'd like me to go back over?
You answered every question I had on the topic.
Fantastic. Awesome. 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 That's great. I think
if there are any more questions for Dave or any of the doctors in our Facebook group, DHEA and Hormone Optimization, leave them under the video. And as Dave proposed, I'll put all the links to the studies in the description of the video as well.
Perfect.
Okay, Dave.
Thank you for having me, Stephen. Hope
Thank
it helps.
you so much. And till next time for vitamin D, okay?
Vitamin D, that sounds good. We'll jump into that next.
Okay. Bye, mate. Thank you so much.
Bye. Thank you.